The data for myasthenia for thymectomy that we had up until very recently was really crummy data that was from large outpatient clinic settings where they would just compile how well their patients did if they had thymectomy or not. So it was looking backwards data. And when you, one of the, well, actually, to say the word crummy is not fair to these docs that did it, because they did really take heroic attempts to try to get all this information out of the old paper charts in the 50s, 60s, and 70s and 80s. And so this is one in the 70s from Mass General where they, looked at numbers of patients who had thymectomy and numbers that didn't, and it did seem that the ones that got thymectomy did seem to do a little better. And Dr. Gronseth and I, before we came to KU, looked at all the papers like Dr. Perlow's, and we put them, we wrote what was called a practice parameter, and we said there's a lot of this data out there, like the Perlow paper, that suggests that thymectomy may benefit, but you don't have any really data to confirm it, and what you need is a randomized controlled trial. And so we suggested that such a trial be initiated, and right about that time, Dr. Newsom Davis in England was thinking about finally trying to get a randomized controlled thymectomy trial done. And it's now done and completed and published, and it's a positive trial, so it's really, really important. And so some of the caveats of this trial is they took myasthenia gravis patients and you had to sign a consent to be randomized to getting thymectomy or not, but everyone got put on the same prednisone dose. So as you can imagine, very few Americans signed up for this study, and most of the patients that agreed to do it were in South America. A lot of them were in Argentina, Brazil, and in Eastern Europe. So that tells you something about how medicine. But we finally did get our 112 patients enrolled. We had one enrolled here at KU, one of our rock stars who got randomized to thymectomy. And that paper came out in the New England Journal of Medicine about 18 months ago, which is a very prestigious journal. So, and I think this is a landmark in neurology research to have the field of myasthenia gravis experts and patients pull together internationally around the world to do this study, which was funded by the NIH, your federal tax dollars. So this was not a drug study, company-funded study. This was NIH funded. That's the only way a study like this would ever be done. And so the two most important data points in this are in these graphs here. And so the red patients had thymectomy and the blue did not. Here the red patients had thymectomy and the blue did not. And what these two graphs are showing with the separation is that if you had a thymectomy, you had a lower prednisone dose, and your quantitative myasthenia gravis score, the way we measure how severe you are, was lower. And the really surprising thing was that we started seeing that separation at 4 months. I always thought that if I sent a patient to Dr. Daon and he did a thymectomy, if you were going to see a benefit, you might not see it for a year or so. But this actually happened much quicker than we thought. So that was exciting. So now we have this, what we call a randomized controlled trial that's very positive. So, in the past, I would, when I would advise patients whether should you get a thymectomy, should you not, I would send people to Dr. Daon and his partners, but I wasn't as enthusiastic as I am now in 2018. Thymectomy's been around since the 1930s. But we just now proved that it really works. So I'm really excited that we have this data now. And so pretty much if I have a new myasthenia gravis patient who's just been diagnosed in the last year or 2 or 3, and they have positive acetylcholine receptor antibodies, I will say more often than not, you probably should go ahead and have a thymectomy, all things being equal. We usually try to wait until we get the myasthenia gravis in good shape so that they have no symptoms or they're minimally symptomatic before we send them to Dr. Daon. Sometimes we have to do plasmapheresis before the surgery to get them in better shape. We were just talking about that. But most people that I send for thymectomy are already on prednisone and pyridostigmine and sometimes other drugs as well. So we really do this mainly for people, the research study was for people who are acetylcholine receptor antibody positive. There are some folks who don't have the acetylcholine receptor antibody. They either have the MuSK antibody, or they have the LRP antibody, or they have no antibody in their blood that we can detect medically yet. Should those people have a thymectomy? That's really the debatable stuff, which we can talk about. And I think they should, actually, but you can argue that we don't have the data for that population. And then we are currently generally not doing thymectomy for pure ocular myasthenia gravis patients, mainly because we don't have the data on that. But would it help a pure ocular myasthenia gravis patient? Maybe. And so I know I had one, since the research study was published, he came in to see me, and he's been struggling with prednisone on and off it and other drugs. And he said, what about a thymectomy for me? And I said, I don't know. No one sends ocular myasthenia gravis patients for a thymectomy. He said, but I think I want to do it. So I'm pretty sure I sent him. Didn't I, Judy? Yeah, we're still talking about it. So I'm open to that. You're not supposed to do thymectomies in very young kids because they need that thymus gland to develop their immune system. So very young is usually like under 3, but anything over that, I would do a thymectomy in a kid with myasthenia. And then we always, from the older literature that I mentioned, we always thought that thymectomy worked less well in older people. And so we would, if someone was old, we tended not to send them for a thymectomy. In this research trial that we just did, we allowed people to be up to age 65. So the question is, how old is old? And I've decided that it depends on how old the treating neurologist is. So we really don't know. I'd probably do it. We could ask Dr. Daon his approach to that, but I would probably do it in anybody at this point, no matter what age they are. And I actually am going to let Dr. Daon, I think I'll stop right about now because he's the expert on the surgical techniques, but I will tell you, in the research study that we just finished, we required every patient to undergo the big transsternal thymectomy procedure, chest splitting, like you get in open heart surgery. And that's just because we wanted to be really purists about it and have everyone have the exact same approach. But now, in 2018, we rarely do those, and almost everyone is robotics, which Dr. Daon's a specialist in, or VATS, and no one's ever going to do that study comparing one or the other at this point. And I don't think it needs to be done. So I think the decision to do a thymectomy now, the threshold is a lot lower because of some of these technical advances.
So I'm going to talk about the surgical aspects, or kind of what it means to have surgery for this problem, which in some ways is kind of relatively simple, and in some others it's not as simple as it seems. So there's different ways to do this. The old-fashioned way was to quote-unquote crack the chest open, which I hate that term, but I hear that a lot. And well, no, it's really not accurate. We carefully open it and then carefully close it. And we do this almost 1,000 times a year for heart surgery, for example, and people do very well with it. It just doesn't sit well with most people when you tell them that this is what they need. It just seems like something barbaric and something difficult to recover from. And in truth, it is difficult to recover from if you're a normal person without a neuromuscular disease. It takes about 2 to 3 months to really get over it, and probably up to 6 months to not think about the fact that you had your sternum opened up at some point. Another method is cervical, so that means making a curved incision at the base of the neck, and we can remove almost all the thymus, or all the thymus that way, by putting some traction on the sternum. I think of the two, whether you get a transsternal or a transcervical, I think the transsternal is a more complete method of removing the thymus. I think the transcervical, sometimes you're not really sure if you're getting all of it, and that's important for this. VATS and robotics, I'm going to lump together because hardly anybody does VATS anymore. We all do robotics. Why is that? Well, because it's that much better. The optics that the Da Vinci robot lets us have, the visual field, the depth, the perception is far superior to what we have with VATS. VATS is basically just video surgery, just like for cholecystectomy or gallbladder surgery. The instruments that we use with robotic surgery are much like our hands. There's actually more degrees of freedom in terms of movement and what we can do inside the chest compared to our own hands. And so it is a technique that really has kind of let us go inside the chest and have the same precision or even more precision than we do with open surgery. This is kind of what the setup looks like, and the patient's head is to the right, the feet are to the left, and you can see there's some endoscopic instruments about a little bit bigger than a pencil, and those are all the incisions that we need to do this. This is me sitting at a console that's away from the patient, so I'm controlling the instruments from that console, and I'm looking in this viewfinder, and this is an example of kind of what the machine does on the inside, and you can see the operator's hands at the bottom mimic exactly the top of the frame. They're doing a microvascular anastomosis, and this is just a demo video, but the blood vessels that they're working with are about 2 to 3 millimeters in diameter, so they're pretty tiny. So what does that mean? Well, it means that we can do a complete thymectomy without opening the sternum, that's the goal. This is what we want to do with those patients. We want to remove the entire thymus because we know that in a lot of those patients, even though the thymus gland involutes over time and turns to fat, there's some little islands of follicular hyperplasia that remain, and that's the source of the acetylcholine antibody production. So it's really important to get it all, basically, and the robotic approach allows us to do that very well. What's the downside, or what's the risk? So this is where it hangs in the balance, and this is why, and Dr. Barohn is no exception. I think we're seeing a trend nationally when I talk to colleagues around the country. You know, before, well, you could really benefit from a thymectomy, but they have to open your sternum. Well, the risk of respiratory failure or not breathing well after surgery is more significant if you've got a big gash down the front of your chest compared to 3 little holes. And respiratory failure is the complication that we fear the most in these patients. There's some other ones, and almost all of them are technical. An injury to the lung, or bleeding, or an injury to the phrenic nerve, which would be devastating in somebody with MG. And we can avoid those. We can actually avoid those easier with the robotic approach. So respiratory failure is kind of the bugaboo of this operation. How common is it? With the series of robotic thymectomy papers that have been published so far, it's less than 1%. You got to take that with a grain of salt. You know, less than 1% means you've selected your patients out fairly well so that they're in class 1 or 2, not class 4 crisis mode. So for the most part, robotics has been a really eye-opening experience, no pun intended, but it's letting us inside the chest without having to open it. I use the robot to do mitral valve repair surgery much more often than I do for thymectomy. And the beauty of it is thymectomy surgery is easy technically compared to an intracardiac procedure. So when I talk to these patients and they come and see me, it isn't very difficult for them to be convinced after they've had some education about it that this is really beneficial to them. And this is one of the few things, believe it or not, where I feel good about telling the patients, well, do I know for sure this is going to help? Not 100%. But the risk of the operation is so low that I think it makes sense for you to take that risk. And it is very personal on their end as far as what they want to do. But this is not like appendicitis where you got a hot appendix and you go pull it out and then the patient's cured. This is, we're going to remove your thymus, and there is a fair to good chance that you'll feel better some, although it ain't going to be tomorrow. It'll be 3 to 6 months later, maybe. But you'd be amazed at kind of the ray of hope these people feel because, they're just seeing the light at the end of the tunnel. So it's been a really cool process to watch evolve, and certainly I'm thankful to our neurology colleagues for referring those patients to us, because I think we make a real difference with that as a team. So the other thing I'll say is these patients are all, they all come and they've been battling this for months and months, and they want to hear that this is going to make them better tomorrow, but it's not. It takes a while, and I think that needs to be reinforced, both on the front end before they come and see us, and also on the back end before they leave the hospital. Typical hospital stay after robotic thymectomy is 1 night, sometimes 2, as long as there aren't any severe symptoms. Here's a picture of a thymus gland that was removed robotically. Here's a thymoma. These are not as common. Maybe 10% of the time I see someone with a thymoma. These patients have a better chance of getting symptomatic improvement after surgery, actually. Here's a picture of somebody with robotic incisions. This patient had actually a right-sided approach, which is a little bit unusual. We like the left side better because the left lobe of the thymus is a little bit larger, and so it's easier to deal with on that side. So the benefits of robotic thymectomy, it's minimally invasive, so people like that better. Their pulmonary function is improved early on. There's a much shorter recovery period, 2 to 3 weeks versus 2 to 3 months. Cosmetic results are better, although insurance companies don't care about that, but the patients sure do. And we're able to do an extended thymectomy, which is really what the goal of this is. The surgery takes anywhere between 45 minutes and an hour and a half, and that's an average. Sometimes it could take longer than that, especially if somebody's had prior surgery on their chest or if somebody's obese. I think that makes it difficult. In terms of timeline, why do we like to do it early? Because that's the patients who seem to get the greatest benefit from it. If it's been 10 years plus, for example, the thymus gland has had lots more time to involute and turn to fat, and there's not going to be as many of those follicles in there that produce that antibody.
So I'm going to kind of cover the preoperative preparation, some management, OR, and postoperative concerns. I try to approach this as being a myasthenic patient because I actually am a myasthenic patient. I was diagnosed with myasthenia gravis when I was 22 during my senior year in college. And so unfortunately I didn't know surgeons like Dr. Daon back then, so I have the traditional sternotomy scar, and I actually got a brachial plexus nerve injury from the surgery. So I would highly advocate for what Dr. Daon does in his techniques, because I think a lot of the surgical risks are a lot less and the recovery is a lot easier for those patients than the traditional sternotomy. So I've lived through a lot of this stuff that all of you are living with, and I empathize with a lot of the challenges. So primarily, I think that it's important to have as your symptoms as well controlled as possible, and so anyone that has surgery is going to have an evaluation by an anesthesiologist once they've been referred to surgery, and we want to get control of the symptoms as much as possible. And like Dr. Daon said, we really are primarily concerned with respiratory function, how well you're going to breathe, are you going to have problems breathing coming off the ventilator from surgery, and so that's a really big concern for us. So there's actually some correlation between how likely are you to have increased risk of being on a vent post-op, and it has to do with disease duration greater than 6 years, and so it correlates with what they've been saying about how if you've had the disease for longer, it's a little bit more difficult to have good results from the surgery, or a little bit less likely. If you're having any surgeries, we always worry about how long have you had the disease. It does depend on your mestinon or pyridostigmine dose. If you're on higher doses, that means your disease is more difficult to control, and so we worry more about that. If you have any lung disease on top of myasthenia gravis, we have a little bit more concern for those patients. It just adds, if you have COPD, chronic bronchitis, chronic emphysema, we really want to make sure that we've done everything we can to get your lung function as good as possible before we do surgery. And then preoperative vital capacity. A lot of patients have pulmonary function tests as part of their diagnosis or throughout their treatment, and so if we have some testing to fall back on and actually quantify what your function is for those patients that we have concerns, if you're one of those patients that's going in for surgery, you may be referred for some pulmonary function testing to just give us a number to correlate with how you're doing, and so we can try to make a plan if you are someone that's more compromised than what the ideal would be. So what a lot of people need to know is the day of surgery, you know, they typically tell people don't have anything to eat or drink the day of surgery. Well, actually, we want you to have a little bit to drink. We want you to have a little bit of water with your pills, and especially for myasthenic patients, it's really important you continue to take your medicine. You know, those medicines are keeping you optimized and on a stable, functional level, and so we want to make sure that you have all those medications in your system for the day of surgery. So that means taking any immunosuppressant medications, that means taking your Mestinon, any other medications you take along with that. And then also if you have any other coexisting conditions, high blood pressure, lung disease that require inhalers, that you should be taking all those medicines the day of surgery. Most institutions have a preoperative screening process where you at least get a phone call from somebody related to surgery and anesthesia. It's not the surgeon's office, but actually is related to the Department of Anesthesia that will ask specific questions and usually give you instructions on what medicines to take and not to take. So I think that helps the patients immensely, that you actually have someone that can go through all your medications and tell you which ones to take and which ones you don't. Because otherwise what happens is people just do the safe thing, and I say, I don't know what I'm supposed to take or what I'm not, so I'm just going to not take anything, and then that way I'm covered. So this way, the screening process, I think, has gotten better over the last 5 to 10 years. There's more emphasis on screening preoperatively, and so the instructions that you should get as a patient should be much more clear. And don't hesitate to ask. If you get a phone call like that and you are getting screened, don't hesitate to ask any questions you have, because that's part of the role of those practitioners, is that we're there to give you information, but then also to answer questions and make sure that we're giving you all the information that you think you need. So typically the day of your surgery, you'll meet with an anesthesiologist that will go over, ask some questions for you about your history, things like what kind of symptoms do you have, what's your activity tolerance, any other medical history, and then talk about the types of anesthesia. If you're not having a thymectomy, there's different types of anesthesia we can do for different surgeries, some that can be used to avoid having to go on a ventilator and avoid having any sort of compromise of your breathing and your muscle strength. But for the thymectomy, there really isn't an option for that. You have to go to sleep to tolerate the surgery. But they'll go through your history with you and then talk about their approach to the anesthesia. So as part of that discussion, the anesthesiologist would discuss with you what he or she thinks your likelihood of having complications with your breathing after surgery, and if so, what the plan would be to deal with that. We do watch our medication dosages during anesthesia. Myasthenic patients tend to be more sensitive to sedative medicines, so we are careful with our dosing of that. And then we also are very aware of medications that can exacerbate myasthenia gravis. I know I heard part of a discussion earlier talking about making sure your primary care doctor isn't prescribing certain types of antibiotics for you that you can't take with myasthenia. And so there are a lot of resources for both patients and practitioners to be aware of the list of medications that can exacerbate myasthenia. I know that if you go to the foundation websites and the organization websites, there's usually links to different lists of medications to help you avoid. The good thing is that most of the medicines on that list are not medications that we routinely give as part of an anesthetic, and the antibiotics that are on those lists are typically, unless you have an allergy to other antibiotics, are not typically ones that are given for surgery. So that's good. I think that the typical patient, if you don't have allergies to any classes of medications, the issue with exacerbating MG shouldn't be a problem with the medicines that you're routinely given for surgery. But it's always good to bring up your concerns and to make sure that your practitioner, surgeon, anesthesiologist, everybody is aware of, hey, there's certain medicines I can't get that would cause a problem with my myasthenia. So there's some of the medicines there, but again, there's more extensive lists that you can find online. So for operative management, just be aware that the anesthesiologist is aware that myasthenics, because of the medication that they're on, they can metabolize medicine a little bit differently, and because of the characteristics of the disease, they metabolize muscle relaxants different. When you're having surgery, often it's to facilitate the surgery, the anesthesiologist gives some medication to relax your muscles. That helps the surgeon get better access to being able to visualize what they're doing, especially with robotic surgery. It helps to have a relaxed chest wall muscles, so it's easier to manipulate the instruments, and so we give medicines to help with that. And one of the medicines that we give, the myasthenic patients are pretty resistant to, but then the other type of muscle relaxant that we give, you're very sensitive to. So we are keenly aware of how those specific medications affect you, and make sure to dose, not only dose cautiously, but we have special monitors to monitor your return from those medications, so that we can ensure that when it's time to wake up, that your muscles are fully strong as they can be, and that weakness will hopefully not contribute to having any problems breathing after surgery. So postoperative concerns, like I said, that we monitor your strength and breathing very closely at the end of surgery. We have different tests that we can do to try to quantify how well you're breathing. As a patient, if you're waking up from anesthesia, you may be awake enough to realize that someone's asking you to squeeze your hand. You may have a very foggy recollection of having something in your mouth temporarily, or coughing. Most people are still asleep enough or unaware enough that most patients don't have any recollection of having anything in their mouth. But for a patient that would be that we'd have concern about whether they're strong enough, sometimes that means we leave that breathing tube in for an extra minute or two, just to really make sure that you're taking good breaths on your own, that you're not just coughing, and we try to make sure that once we take that tube out, that your strength is going to be strong enough to breathe on your own. So there are a small number of patients that may, after you ask them in recovery or when they wake up a little bit more, say, yeah, I remember having something in my mouth, or I remember coughing a little bit at the end, but it was pretty foggy and I wasn't really concerned about it. And most patients don't really have any recollection. But if you're someone that does, it's usually for a specific reason that we've been concerned, and we want to give you a little bit extra time to breathe on your own. So one of the biggest risks that we talk about, that both Dr. Daon and Dr. Barohn have talked about, is we are concerned with respiratory failure or breathing problems after surgery. And so that's why we monitor the strength so closely. If you're someone that at the end of surgery that you're not breathing well enough on your own, that the stress of surgery has caused you to be weaker than you were previously, some patients do end up being on a ventilator for a short time. If that does happen, patients are given sedative medicines, so there usually is not any or much recollection of anything happening. So if they do have to have you on a ventilator for a brief period of time after surgery, you're kept sleepy so that breathing tube doesn't bother you. And most patients, when they finally get the breathing tube out, don't really have any recollection of, or even awareness that hey, the tube was in a little bit longer, or they were on a ventilator for a while after surgery. But the goal is always to get the breathing tube out and get you off the ventilator as quickly as possible, hopefully at the end of surgery, but if not at the end of surgery, as quickly as possible and as safely as possible afterwards. So like I said earlier, the patients with myasthenia are sensitive to narcotics and other sedative medicines. So as a result, for pain control after surgery, we use a lot of non-narcotic medicines. And that's been a big movement in general for any patient. Especially for myasthenic patients, we use things like Tylenol and gabapentin and other medications that provide adequate pain control in combination with other medicines without having to give large doses of narcotics. And that's one great benefit for the technique that Dr. Daon uses, is that the postoperative pain isn't as significant because the incisions are small, and so the recovery is a lot smoother and the discomfort is a lot less. So I think that's really been a great development for all myasthenic patients having a thymectomy, is just the improvement of the technique has been helpful for the anesthesiologist, because we have patients that aren't having to deal with as much of a disturbing their breathing as much and having as much pain waking up with surgery. And so I think it really has benefited the patients.